Okay, so this presentation is going to be about eye surgery, and it's specifically targeted at biomedical engineers and biomedical engineering students. Okay, so first thing is, what is the greatest weakness according to Dr. Abdul Kalam? Anyone know about this? Not a very hard question. I have some hard questions down the line. Something very easy to start with. Some of you might also already know or heard of this question from me. What is the greatest weakness according to Dr. Abdul Kalam? Weakness of a nation, let's say. No one?
Nation without vision. I just read it.
Okay, at least, yeah. Yeah, it actually, in these interactive classes, you have a couple of seconds to quickly Google and read, right? So you should try that. So a nation without the vision is actually one of the greatest weaknesses according to Dr. Abdul Kalam. And this talk is closely related to vision, the lack of it, or getting it back. Okay, so vision is quite you know quite broad. Let's look at eyes and know how evolution of eyes, how eyes evolved. Someone's speaker is very noisy. Okay, so notice roughly from A, B, C, D to E, E, F. This is how human eyes kind of evolved. Okay, what this is evolution of a mollusk eye, but roughly starting with some kind of sensors to sense light, right? And then that takes it to a processing center. Okay, so just some photoreceptor cells. That is how eyes kind of started. Okay, over time, okay, you want to sense light from a specific direction, right? No point sensing light, just getting a blob of white light. So you get this sense of directionality using change in shape. Then that shape kind of changes more and more, and most of this evolution happened when the eye was inside the water, right? So you also have this chamber where now you have a water filled chamber that have like better directionality, sensitivity, and almost like water is going to act like a lens of some sort, and this is going to behave like a pinhole thing. Then nature evolved further, right? From transparent humor, we have an enclosed chamber. Obviously the need for this is right apparent. We don't want to just stick to water, we also want to get out of water. And in order for us to keep our eyes working, we thought, okay, why don't we just put water inside the chamber itself? Why use external water? And from there we developed a specific lens to actually see. And then not just a lens, so now we got the ability to focus with, along with iris and couple of other mechanisms, we got the ability to change focus and all the things. Of course, also the photoreceptor cells also kind of evolved, pretty much every part evolved. So starting from distinguishing black and white light, we started seeing colors and whatnot. So roughly this is how eyes evolved. And in fact, the term vision that I mentioned earlier, it's actually much more broader. If you actually think of a human eye, what it is capable of actually perceiving is, let's say, in frequency, or okay, at least let's get to this thing in wavelengths. Somewhere in the small wavelength region, right? We have like 700 to 400 nanometers. That's roughly what we can see, right? But our perception is not limited to that very, very narrow range. Okay. That is one of the beautiful aspects of, you know, aspects about vision. Doesn't stop with, where, what you are capable of looking. It actually expands to what you want to see, right? As human beings, we develop this curiosity to look at smaller and smaller things as well as bigger and bigger things. Along with that, though our eyesight is restricted, right? Our vision is like our eyes are restricted. Our vision kind of expanded to scales, well beyond our senses, right? We can right now uh, play around with atoms, and also in this side we can play around with universe and all that. So vision is a very, very broad term in the sense. I don't restrict to just looking at some wavelength or something like that. So this kind of generalization, you could also map it to semantics. That is, visual is not looking at details but also how you interpret the detail and all that. One could go one step further. Vision is also about looking at things that that are not there yet. That is, a century back, the concept of atom, nuclei and all were not there, but someone thought, okay, what if we keep on dividing matter, what will we find at the end of it? That search is also kind of comes under this term vision. Okay, so the point to raise this notion of vision is that now we suddenly lose that sense, right? We take so many things for granted, and someone loses their sense of sight. Okay, not vision but sense of sight, that is eyesight, right? You could imagine the kind of uh, damage that could do to the person's life. And specifically, there is this preventable blindness. Okay, there are blindness that we humans are not capable of preventing or correcting yet, and then there is blindness that we humans are capable of preventing or correcting. Okay, so this is something that we can certainly do something about. Okay, we can fix it, so why not fix it, right? So preventable blindness, even in blindness we are going to focus on a very, very narrow region called preventable blindness that causes that takes away someone's ability to see, along with it a lot of lives uh, capabilities and opportunities. So it's a very, very eye surgery is a very, very special role in medicine. And I thought if even if you have to discuss one topic, it better be this eye surgery. Let's get into some details of anatomy of the eye, just to make sure okay, not all of us might know the anatomy. Roughly, okay, we have the lens over here. Okay, this oval, distorted oval shaped thing is the lens. Then we have the iris and all that to control it. The lens is attached to the surrounding tissue using some kind of microscopic muscles and all that. Then we have this almost a water-filled chamber, vitreous chamber in this side, to some extent, yeah, humor in the front of the lens and on the behind the lens. Okay, then we have the retinal cells here, blood vessels and nerves connecting the retinal cells. And then there is a black spot called fovea. Then this part of the eye is called sclera, and then we have the cornea and all that. So, and our focus of this is going to be on the lens. Okay, someone's if your mic is noisy, please mute it down. Okay, do it yourself. And so our focus is going to be on the lens. The point is, so any biological system like this, we already saw, starting with photoreceptor cells, things kind of evolved into this kind of a magnificent mechanism to actually see, right? Any part of that mechanism can fail. Okay, and to give a proper direction to our understanding. Again, just like directionality of light, we also want a directionality of exploration and understanding, right? To make our understanding more directional, or gaining of knowledge more directional, what we are going to do is, a problem occurs with this part of the eye, the lens of the eye. Lens is supposed to, yeah, refractive thing that's supposed to focus, put project light onto this thing. But what happens if that lens that is supposed to be transparent becomes opaque, right? So to make our study more organized, we are going to focus on this one aspect. This aspect happens with pretty much any part of the body, starting from balding. You have this hair all over your head, suddenly it starts dropping, right? Something like that also happens at different scales, at tissue level scales, at protein level scales and all that. In this case, there is a protein level conformation change that happens with age. And with that, what happens is, macroscopically, there is this lens becomes opaque, so that no light can enter, and person kind of becomes blind. And if you also roughly look at that specific problem that is known as a cataract, that is this iris becoming opaque. So because of that, typically during aging, because of that, a person cannot see anymore. That is known as a cataract. And interestingly, this is preventable. And the broad term for that is cataract eye surgery. And so this is going to be our focus and scope for today's discussion. And if you notice, a cataract surgery also accounts for majority of causes for blindness. 60% of the blindness is going to be cataract surgery. Then there are some refractive errors. Okay, you are not able to, it's either myopic, and all that. You are not able to project it properly. Lens is distorted, eyeball is distorted, and all that. Those kinds of error makes up for 20%. But notice 60% is mostly blindness due to cataract. Okay. So what we are also focusing is in a very, very major problem, not just small problem. So just because someone's lens becomes opaque, they cannot see anymore, and yeah, that creates a burden, right? Interestingly, that burden is creatable and preventable. So this is how that looks. This is one of the, I think, advanced stage of cataract. This lens that is opaque, transparent, kind of becomes very, very opaque. So this is preventable blindness. That is, something can be done about this opaque part, restoring back vision. Okay. So let's look at that aspect. Very, very focused thing of aspect. Okay. Burden of preventable blindness, we already discussed. Someone loses their eyesight, and we know the consequences. At least we could foresee, empathize the consequences and all that. Okay. Has a major effect on someone's life. In terms of numbers, okay, some of these numbers are actually, helps us, fix nice targets, make our vision very, very specific. Okay, this is based on 1999, 20 years old data. Okay, roughly, 12 million people are blind, and every year we have like 3.8 million newly formed cataracts. And this cataract is preventable. We can do an operation and prevent it. And roughly we do like 1.6 to 1.9 cataract operations per year. That means, so each year there is going to be like a deficit of about 2 million people will still be blind, will still have preventable blindness, and the next year that 2 million will keep on accumulating. And we also have a reserve to start with. We have like 12 million blind people to start with. And one of the estimations says this around 2000s, 5 to 6 million operations per year would be needed to tackle the accumulation of cases. Okay, So this is a problem. Now, right now, okay, we are doing cataract surgeries, but about 2 million people are not getting that due to various reasons, which we'll see. One of them primarily being the cost. Okay, say they couldn't afford it. How can we increase this to 1.6 to 1.9 operations to 5 to 6 million operations? Major barrier is cost. If you have money, you could, like, of course, move things in the world, but uh, can we somehow overcome this barrier? Okay, and this story, in fact, is going to be about some successes on how we actually did this. Okay. Okay, what is cataract surgery? Let's understand that. Interestingly, things started with, we were pioneers once. Sushruta, right? Most of you might have heard about him. He was doing cataract surgeries in 600 BC and all that, before Christianity, right? This is like long back, many, 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 many centuries back. And in fact, he had like descriptions of a surgery in Sanskrit. The translation is given here. Notice, okay, put a sharp needle, puncture the eye, somehow reach that lens that became opaque, remove that opaque. Vasalva is like you hold your breath and try to hold your nose, close your nose and mouth and try to breathe out. The idea is that lens kind of comes out of the incision that you have made. Interestingly, notice there are also post-operative procedures. Okay, apply some indigenous roots and leaves, apply some herbs so that you avoid infection, further complications, and then also lie flat and avoid some strenuous exercises. Of course, you don't want to be sneezing and all that, right? So interestingly, all this was there starting with described by Susuta in his book on surgery, of course. And this was performed in, 600 BC, pretty way long back. Interestingly, what happened is we look at a proper evolution of course, we were doing this once, but uh, history is typically seen through Western lens. Okay, so we'll also look at that thing. And then we have this, what used to happen is, of course, later around, I'll show the dates. Uh, Doctors in the West kind of realized you could just remove that opaque part out of the eye. Okay, either initially they were moving it out from the optical axis, and then they started actually removing it out, out of the eye. And for a long time they thought that's a good idea, and then until someone realized, why don't you replace what you're removing with a proper lens? Okay, so those are known as intraocular lenses. Once again, is the cracker noises too loud, or is it like, can you all hear? Is it feeble?
Yes.
Feeble or like very jarring? Okay, it's fine. So notice, so initially they were just removing that opaque part out of the eye, and then it took them a long time to realize actually you could put some kind of artificial lens to fill that gap. Okay, and before they put it, they were actually, okay, the eye doesn't have any lens, so you will have to put a very, very, very big lens outside of the eye, right? And this is a fake kick spectacles is like for a lens, spectacles for eye that doesn't have a lens. Okay, and this again came up with a lot of problem. The issue was that uh, most of them, first of all, maintaining this is going to be hard, kind of things break over time. And second is, importantly, most of the people who actually had this cataract surgery were essentially blind. About 50% of them were blind, after some time of the surgery, because they were missing a proper lens. Okay, and this is where, in fact, this IOLs, intraocular lenses, came into the picture and changed it. Okay, So let's have a quick question. I have been talking for a long time. I have shown something in the slide. What do you think it is? Start from Keshav again. I can help you with, at least getting to the description as precisely as possible, but at least, I can help you with cues. What do you think is shown in the figure?
Something related to eye, sir, but
Okay, something related to eye. Okay, related to eye, but somewhat relation is right now far-fetched. Okay, in fact, we have like, better question in the chat. Can you send that as a message to everyone instead of a direct message? Some kind of a ketone or aldehyde. Okay, it's some kind of a chemical structure to start with. Now with that, can you be more specific about the kind of chemical structure it is or what chemical structure it is? Can you identify any elements, any functional groups in it? Any of you?
maybe aldehyde group, sir.
Yeah, ketone or aldehyde is the guess. Slightly different.
Acetaldehyde.
Acetaldehyde. Let me interpret. Not acetaldehyde. No, not that. Let me start at least pointing you towards specific details. What do you think is this bracket along with the N?
The component may be produces as a n times.
N times. So what is?
It is a polymer, sir.
Okay. Now you at least got it. It's some kind of a polymer. So if you know what the monomer is, you know what the actual polymer is, right? So N refers to it's it repeated N times. It's kind of like a chain. So what is a monomer? So let's also get some kind of hints into that. So what is this one line point to? What is a line here in this kind of a picture? Do they show what kind? So what are two lines? What is one line?
Sir, the bonding
Bonding between?
carbon and other.
Yeah, usually bonds between carbon and carbon is shown as a line in organic chemistry, right? So this is actually at the end of this is a carbon, and it's not connected to anything else. That means there is one bond here. There should be three other bonds here somehow. So the hydrogen is not shown. So this is a methyl group. Okay, so there is a methyl here. There is a methyl somewhere else in the picture. Where is it? There is a methyl here
Starting
at the top. So there is a methyl here, methyl here. Now, can you be slightly precise about what kind of
maybe polymethyl methacrylation.
okay. Now at least you guessed it, right? Yeah, this is an acrylate. Okay, this is COOH acid group, and that is actually methacrylate. Okay, and there is a methyl group there, and there is a methyl group here. So this is polymethyl methacrylate, and yeah, this is related to ice, not dimethyl, methyl methacrylate. Okay, PMMA. And this is what the intraocular lenses are made up of. Okay, so notice they started doing this kind of cataract surgery long back. Okay, 19th century and all that, 18th century and all that, but only in 1950s the first intraocular lens was made. Okay, or actually implanted, to be specific. And that intraocular lens is actually made up of PMMA. Okay, polymethyl methacrylate. Now comes the another interesting question. So how come they figured out PMMA is a biomaterial, is biocompatible. How is there anywhere to figure out this is actually biocompatible? How did they figure it out? Any of you wondered about it? Yeah, we have seen PMMA as a biomaterial and all that. It's used in many places, but how do they figure out it's good? You know, it gels okay with the body.
Sir, I have a guess.
Uh-huh.
Can I guess it, sir? Sir,
What is it?
due to a polymeric structure, uh, the individual bonds are just bonded together.
Mm-hmm.
So there are no free bonds or any free radicals present there. So
Mm-hmm.
it would be less reactive with the surrounding bonds.
Okay, the thing is, okay, this is less reactive. This is like quite stable. You're trying to say, okay, there's a polymeric chain, quite stable and all that. But the surrounding thing is not less reactive. Body is like looking for opportunities to react, right? We have this immune system.
Sir, maybe the resistance, sir.
Resistance. Interestingly, this is just a somewhat of an accidental or a serendipitous discovery. Okay. So PMMA was kind of, they started making it, you know, they chemists kind of discovered it, and then they realized things made with glass, PMMA is a nice substitute. The glass kind of shatters, right? And many handling difficulties are there. PMMA also kind of shatters, but you know, it's a plastic, very different from glass. So PMMA started replacing glasses in many objects. This was mass manufactured. And when they actually realized PMMA is a biomaterial, was during Second World War. It was actually an observation that, you know, pilots had a lot of eye injury because their cockpit, the window in front of them used to get shot, and many times the shattered particles will end up in their eyes, also in the part of the body. This is what doctors noticed. So pilots who had like a glass pieces, uh, you know, in them, in their eyes, in their body, they had much lesser recovery compared to pilots who had this PMMA in their body. So they realized PMMA kind of, it's much better compared to glass. That's where they started recognizing that as a biocompatible material, because those pilots who had PMMA in their eyes started recovering faster. Okay. And so they realized it's a biocompatible material, and then they realized, okay, it's okay with the body. And then they started making things using PMMA. That is, okay, now it's compatible. Now what kind of a material do I make a lens with? Plastic, no transparent lens. Of course, what you would go for is a PMMA. This is what happened in 1950s and 60s. 50s, they realized it's biocompatible. And soon they, here in 50 itself, someone went and put that in the eye. So before 1950, what happened is they'll remove that opaque part out of the eye, and the person will not have, that part will be empty. Uh, that lens won't be there. Sometimes some of them had spectacles outside. Only in 1950, they put a lens, artificial lens, intraocular lens inside the eye. Okay. And this is how discovery of PMMA as a biomaterial arose. And of course, the moment this happens, notice it's very hard to actually say whether something is biomaterial by looking at its chemical structure, physical properties. Very, very hard. Things are, discovered, and the knowledge is built over time. Okay, PMMA is biocompatible. Now, if I perturb this structure, will things still be biocompatible? Which other polymer is biocompatible? Now, one could go start doing that research, because the first time you realize, okay, your polymer, the polymer can be used to, manufacture that something that you can implant into the body. You realize that now you are looking for other options, right? So we don't need that to be transparent for some reason. Okay, we need a slightly different kind of polymer. Will that be stable? Their research starts. Just do experiments with animal models and all that. But the starting thing was PMMA was just serendipity or like, almost by chance or luck, some keen observation by doctors during Second World War. This is how this happened. Okay. And I have also shown one more interesting discovery that plays a very important role in cataract surgeries. And I have shown his pic and I also put up his name because, of course, it wouldn't be fair to make you guess his name. But his name is Rangaswamy Srinivasan. Any guesses what he did? He did some pioneering work with one of the medical devices, or something to do with medical devices.
Sir, when I was just doing my seminar, I saw this name, Sir Rangaswamy Srinivasan, in LASIK eye surgery. Maybe
Wow.
something related to him, sir.
What is the similar? When was it?
So, but I have come across this name, Sir Rangaswamy
You have come
Srinivasan.
across his name. Okay.
Yes, yes.
Okay, excellent. Okay, so you have some amazing memory. So notice Rangaswamy Srinivasan was more like a physical chemist. Okay, but he's also like a, eminent bioengineer or a biomedical engineer, because he the laser surgery and all that we do, LASIK, I don't know, eye surgery, laser eye surgery and all that. He came up with this thing, with the technology behind creating laser eye surgery. In fact, for that, he was honored with Roos Prize. Okay, that is given to pioneering bioengineers. So I will always put him as a biomedical engineer. Okay, by function. And he discovered something with lasers. He was working with lasers and he discovered something. And that discovery had a very, very interesting consequence again in eye surgery, technological development of eye surgery. So let's also understand that scientific discovery and or invention. Okay. So again, I have shown a picture. It says IBM. This Rangaswamy Srinivasan was working with, of course, IBM. He was a scientist with IBM. Okay. So shown something, what is it? Someone kind of already, I just read. Where did you read it, Akansha? So, okay, ablative photo decomposition is one of the commons in the chat. Yeah, invention, again, we have another answer. Invention of LASIK eye surgery. So what was this invention about? Did he invent laser, or like what was interesting about what he did? Again, this will help you, put in the shoes of pioneering eminent scientists to actually, where were they? What was the discovery or invention? Can you be more specific and to actually aid you with the answer? I have shown a figure. So what is ablative photo decomposition? I mean, Latin roots and all that we know, right? Ablation, we know what ablation is. Photo, we know what. Decomposition also we know. Can you try to, anyone make, guess what that likely means? Meenakshi will kind of think for a few seconds and then suddenly come up with a good answer. Others, Nandini, Urvi, Mega. So notice what is actually shown here is a photograph of a human hair. This hair, right? One of the hairs is shown, and in that there is an etching of course, this IBM, right? So he discovered a type of, he was working with lasers. Concept of laser was already there. He was working with a type of laser, excimer laser, okay, with an interesting property. He noticed he could be, He was working with a specific protein. Okay, whenever that laser hit that protein, he recognizes that protein kind of decomposed, disappeared without a trace. That was very, very important. Typically, what happens is when you, of course, shine powerful laser into, tissue, not necessarily tissue, wood, anything like that, there is a lot of surrounding thermal damage. Material get charred, thermally things get heated up and all that, right? He noticed that excimer type of laser had no thermal damage to surrounding tissue. Wherever the laser hit, that part kind of disappeared. Surrounding part was like doing fine. And this is where knowing things, both depth, breadth and depth in knowledge helps. Of course, to do this kind of experiment, his depth, his expertise in laser technology was very well good. But he also had a nice level of breadth. He realized the same kind of proteins also show up in living tissue. Okay, he was not working with living tissue. He was working with some protein molecule, something crystallized protein and all that. But he realized living tissue is also made up of that. What if this laser can also behave the similar way with living tissue? That is, etch or remove tissue without thermal damage. He guessed it. He also, recognized, okay, his laser could do that. That is, etch, remove minor, very precise etching of living tissue kind of became possible without affecting surrounding tissue, predominantly thermal damage. And this is also shown here, illustrated here. Things can be very, very precise. So what is the scale we are looking at? This is human hair, and there is this etching of IBM in that. You can remove very, this is precision etching of living tissue and with almost no damage to surrounding things. So that is why his work was very pioneering. Now that this kind of possibility is out there, of course, other engineers followed suit and, okay, now can we start applying it for different kinds of medical applications? And one of them was, of course, can we do laser surgery? Okay. Again, so this is the discovery of, or there's a story behind this laser eye surgery. Interestingly, laser eye surgery is done for refractive problems. Someone has short sight, far sight, someone needs to wear spectacles. You can etch that, reshape that eyeball to a better shape. Now we can do it very precisely without affecting surrounding tissue. So that is known as LASIK. And so that is, but that's for refractive surgery. Notice we have been sticking to cataract surgery, right? A form of this shows up in cataract surgery. Okay, CS is cataract surgery. Femtosecond laser assisted cataract surgery, FLACS. But interestingly, for cataract surgery, laser is not that important, or doesn't show comparative relative benefits over other methods. We'll all, of course, look at what the other methods are, what doctors do. But so two interesting things. Someone working with laser came up with an interesting observation that ended up with this amazing thing called laser surgery. You have to do some eye surgery. You have to wait for your eyes to heal. It takes week, 2 weeks, a month, whether it heals right without infection. That used to be the case. I had my mom go do laser surgery. She, the next day she was like, I think she was fine. So this of technology changes things. And of course, PMMA, another interesting thing, biomaterials that we are working with. Now you can replace body parts, something that, outside of things. That again is some interesting discovery that happened during this, evolution of cataract eye surgery. Okay, with that, here is actually a summary of how this surgery and technology evolved. Okay, started with this. So yeah, Sushruta was one of the first, in fact, documented, written, documented in written form. He was doing something called ECCE. Okay, we'll get to that in a moment. It's a very primitive version, not the modern day version, but he did do something what others, in the West were doing in 1700s. To be first time ECCE was done in 1747. Our pioneers, father of this surgery, right? He did it in 600 BC. While we Indians were doing it, the rest of the world was doing something called couching. I already mentioned this. This is like, okay, now you have an obstruction in your eyesight. Why don't you poke it and slightly move it out of the axis? That lens, why don't you slightly move it this way, that way? That was in fact, the norm. They started doing this around, 5th century BC until like 1750s, right? Where a couple of interesting things happened. This first ICC and first ECCE, coaching was there in practice. That's when some ophthalmologists typically, okay, not engineers, doctors, recognized you could do some kind of surgery other than moving the opaque part, to the left, to the sideways away from the axis. You can actually remove it. This removal can be done in two ways. One is ICCE and ECCE. And then this followed suit for actually a long time, for about 200 years, starting from 1750s. First of all, one doctor performed it, did not mean other doctors started performing it. There is usually, resistance for an idea to be accepted by others. Took them 200 years, and by 1950, someone did the first thing, IOL implantation. Okay, you are removing that part. Can you actually replace that with something, with an artificial lens? And this also, happened, soon after the Second World War, when we had this knowledge of PMMA and all that. Okay, from there we have some technological innovations, phacoemulsification, and the idea is, yeah, we'll get in the details of this in a moment. Primarily, okay, like how big a cut do you need to make to remove things? Okay, what are you removing? How are you removing it? To be precise, how big a cut are you making to remove what you are removing? And then after removal, what are you putting back in? So that those three things will primarily determine all this technological evolutions. Okay, and so first IOL here, then someone thought, you could instead of removing that opaque part as such, it's like a big chunk, right? Can you emulsify it? Can you liquefy it and kind of straw it out, aspirate it, right? You can liquefy things using ultrasound. You take a needle, vibrate it fast enough, okay, near any material, that material will start liquefying due to shear, right? So that is known as phacoemulsification. This was discovered in 1960s, 67 to be precise. Then, okay, you are removing this, fine, but what you are putting in is like actually very, very big, right? So the cut needs to be big. Then someone came and thought, like, instead of this, we have now foldable smartphones, right? So like foldable smartphone, what if we have that lens to be foldable, so that its size is small when you insert it, and then it kind of opens up into a proper shape once inside the incision, so that the cut size can be smaller. Someone discovered that, thought about it, came up with it, invented it in 1978. Okay, first foldable IOL. Then we have a couple of more things. Yeah, FLAX is this femtosecond laser assisted cataract surgery. Okay, this was approved by FDA in 2010s. But interestingly, this did not have a major impact in terms of, there are other factors, right? Okay, now there is technology, but there are also questions of adaptation, and then what is the cost of things, right? Because of that reason, how you do this operation called, M6 here, we'll get into what that is here. It's essentially a type of this ECCE, and that is done manually. this kind of become, this was discovered in 1990s, and this is like now one of the best things that we have. Okay, so let's get into details of some of these surgeries and involving technology, and not details as in let's not do again engineering type of detail, but let's look at what motivated all these changes from a functional point of view. Again, I showed this picture of evolution of eye, right? Something like that also happens with technology. Something evolves, it happens for a very good reason. Okay, all these evolutions are very directional, happens for a good reason. Let's try to understand the context behind all this evolution, how things evolved, just like this. PMMA and what is the other thing? Yeah, this laser etching, right? Let's get a feel for that. So intracapsular, extracapsular cataract extraction. I show the lens part in the eye, right? What is shown here is just that lens. So the lens alone has like a pocket. It has an anterior side and a posterior side. All of you know what is anterior, what is posterior. So you know how this is actually located in the eye. And then notice the actual lens, there is a nucleus of the lens, okay, surrounded by a region known as cortex. And then we have a couple of protective layers. So of course, this is connected to surrounding muscles, iris and all that. So ICCE, ECCE, we have CE is cataract extraction. This opaque part you want to remove it. Intracapsular cataract extraction, what you do was this, you remove this nucleus part of the lens, just the lens, not the capsule. That is ICCE. ECCE, you remove the entire capsule. Okay. And of course, if you want to remove the entire capsule, that comes with, how do you cut all these muscles? Comes with a lot of questions, comes with, how big an incision do you make and all that. And of course, that how they addressed us, we'll come to that, but that is known as extracapsular. So removing only the lens part, that is ICCE, removing the entire thing, lens along with whatever it is surrounded by, the region, that is ECCE. Okay. And here, let's look at again this, again, as Indian biomedical engineers, we should look at things from perspective of developing world. In 1990s, this was the scenario. Okay, rest of the world was doing this ECCE with posterior chamber IOL implantation. Okay, forget posterior chamber. The idea is they are doing ECCE. That is, they are removing the lens along with the capsule, and they were putting in a intraocular lens. This was a standard of care in developed countries. Okay, but this needs high-end equipment. Notice, first you need the lens to put inside it. Intra-IOL you need. Okay, how costly is it? Then you also there is a need to make some very precise surgery, surgical precision or precise surgery in order to remove the entire capsule. That was a standard. Okay, what we were doing in India at this time, 1990s, was predominantly this ICCE with aphakic glasses. ICCE, you know what it is. That is just removing this, the lens part. The problem with that was it had a lot of post-operative complications. Okay. Results were substandard. Most of them had complications. Notice if you just remove the lens, now you kind of do a structural damage to the eye. The pressure in the eye changes, all of that. Because of that, doesn't heal. If you remove the entire capsule, kind of it heals better. Okay. So ICCE had a lot of complications. Outcomes, that is what happens after surgery, number of infections, complications were high, or the results were substandard. But even this was not the standard in India. What was the standard was ICCE with aphakic glasses. That is, you do remove the opaque part, you put in, external this glasses, which are quite big, right? Problem, we already discussed problems with the glasses. Aphakia, glasses break, most of them end up being blind. And also this thing takes several weeks to heal, ICC. Okay. The beautiful story is 1990s, this was the scenario. Interestingly, by, in a span of 30 years, okay, 2010, 2020. So the work for this started, well, before 1990s, 1980s and all that work started. But we started seeing amazing results by 2000, 2020, certainly, Vision 2020. By then we had some amazing progress. Even by 2000s, we had some amazing progress. Okay. So how we went from here to here, that is something that there is a high-end equipment, standard in developing countries, but not at all a possibility in a developing country. The transformation happened. Very, very magical, very rare transformation. Okay. Let's understand that story first. Of course, and once we understand that story, we can go further. Okay, what is going on later with this? That story, that's a technical detail, not an interesting story. Very, very briefly, yeah, they do phacoemulsification. That is, the surgery size was kind of brought down. You use ultrasound to emulsify and aspirate, make it, liquefy the glass and suck it out. And then there is this M6, right? This is, again, for phacoemulsification, you need some high-end equipment. Can you do the operation manually, make a very, very small incision that will heal on its own without a suture and all that? Okay, that is known as M6 manual small incision cataract extraction. That doesn't need a suture, any of that. Okay, very low cost and all that. This is in 2020. This is kind of like one of the best means available for developing countries. But in 2000s, this is where we are. From here, we somehow got here in a span of 20 years or something like that. So let's understand that. Okay, this difference is extremely, extremely important. Imagine so many people, millions of Indians who are blind. That blindness is preventable, but what we are currently doing doesn't really cure their blindness. What is being done elsewhere is extremely costly. There are lots of barriers to getting that to here. So how was that overcome? Okay, that's a very interesting story that all of you should know as biomedical engineers. Let's look at that story. Okay. And the hero of that story is Dr. B, or Dr. Govindappa Venkataswamy. Okay, he is from Madurai. He became an ophthalmologist, one of the leading ophthalmologists, and he was the person behind this transformation from getting to this AFK classes, ICC with AFK classes, to that is essentially blindness remains preventable, blindness still remains a blindness, to a proper what was available in the West, he brought it to a developing country. Okay, so the person behind that is Govindappa Venkataswamy. So what he did, of course, along with his team, is this thing. In one line, the IOL, right, the PMMA lens that you are making, that alone used to cost $100. Back then, it used to be like roughly 4,000 rupees. Okay, these were imported. He started manufacturing them in Madurai for a cost of $4, about 200 rupees. So one of the things that happened in the transformation is the cost of intraocular lenses came down. This is orders of magnitude difference, right? 10 times, it's not even 10 times, it's like 2.5, 25 times the cost reduction. This was one of the things happened. So we couldn't afford it. Doesn't mean we don't do it. What we do is we make it affordable. Okay, and in one line, quantifiable terms is what he did. So he started manufacturing IOLs at very, very low cost. Okay, and there are also many other interesting healthcare evolutions revolving this. Okay. So typically, before we go deep into that story of the transformation, such a transformation did not occur in, surgeries outside of cataract surgery. That's a reason to have this conversation with biomedical engineers, specifically biomedical engineering students, right? We have amazing healthcare technology, but the technology is not affordable and accessible to a majority of the population in the world. Okay. So most of this technology is there in developed countries. Okay. It's cost very, very high. That is one of the biggest failures in taking this technology to a developing country like India. And then there are diseases that are very, very specific to developing countries. These diseases are not there in developed countries. Okay. Couple of example, malaria is, India, it's there, mosquito is a big problem. Many states in US, mosquitoes are, very well controlled. There is no stagnant water and there is like amazing mosquito control issues. Right. And then with respect to eyes, fungal infection of eyes is something that is very, very prevalent in a developing country like India, not at all there in a developed country. Right. So many times the state of the art technology or solution is actually missing because the diseases are specific to resource poor settings. Third is again the most important thing, takeaway point. I want, this is one of the major takeaway points for all of you. Whatever they design for a developed country, it's inappropriate. Many times it's inappropriate for, for a developing country. The context is very different and it's extremely important. So let me give you more specific examples again in terms of eye surgery, cataract eye surgery. This transformation from ICCE to ECCE, the standard Western standard that came to India because one of the things that was done was cost reduction. So high cost, okay, bring down the cost. Second is cost reduction often needs to occur in tandem with production of neglected or unavailable pharmaceuticals. There is a fungal infection prevalent in India. It's not there in a developed country. We need to develop that pharmaceutical, that drug or antifungal thing. Okay. And they are not, the market is not there for the developed country. They are not interested. And developing country, by that we mean they cannot pay a lot for it. So this is our own problem that needs to be solved by ourselves. And again, an example is there used to be fungal infection in the eyes and antifungals were developed for it. The most important detail here is this inappropriate design. Okay. So often a lot of things change, context is very different. In a developing country, you have a refrigerator. You can put things, store this medicine, refrigerate this medicine after receiving, after opening. Such a possibility is not there in India, right? So there are cold chain issues. Okay, there is no electricity to start with. You need a sterilization. You need a sterilizer that works on electricity. You don't have electricity in a remote rural place, right? You don't have a refrigerator at a remote rural place. And so the context often is very, very different from the context here. And in fact, to give a more relatable example, phones, right? The smartphones these days in the developing countries are designed such that they will fail in a matter of, if it lasts for a year, that is very good. Many times the battery design is such that you will have to change the phone after, 2 years, right? But our context is, we have solutions where we have the sachet packets. People get daily wage workers. They cannot get, they cannot go for monthly groceries. We need these pouches, small patches that they can use every day. Right? That is packaging. Sachets was a major revolution and in marketing and uh, in this sector in consumer goods sector, right? Similar things also applies for drugs. uh, is it for one drug? Can 5 patients be operated with that one vial we have? Okay, vaccines, you might know the story. 20 patients, uh, 20 vaccinations can be done using one vial in a specific time window. Does it suit the condition? Right? And often medical devices, sutures, uh, catheters, most of that are thrown away after first use, or they are designed to, pressure catheters that I know of will be thrown off after, they are designed to fail after work for only 3 or 4 uses. After that, you have to use a new catheter. If it works for three uses, that is very good, right? But in an Indian context, we want to reuse things. The same scissor we want to use for the subsequent surgery too, right? So the context often is very, very, very different. And many times, so we cannot directly take a developing technology and put that to use in a developing, healthcare setting. Okay. And in case of this transformation, all three things successfully happen. So in case of this transformation from ICCE to ECCE, all the three things successfully happen. Okay. And the first thing we already spoke about. So here are some actual numbers from, what is the cost of the surgery to quantify things. At the end of the transformation, cost of eye surgery in India became $15 to $20. Okay, things became very affordable. The IOL itself, like $4 to $5, 200 rupees. This cost like, okay, 800 rupees, something like that, to do the entire surgery back then, 2000s. At the same time, while we got to this stage, United States, it cost 1000, 1600 to 2500. You could, this is 2 orders higher. That is a kind of change, transformation that happened. Okay. And so make any technology available only if you make it affordable. Okay. That thing becomes, really use. That thing gets to widespread use. And such a beautiful thing already happened. There is one instance. The idea is, can you learn about this instance and replicate it in, other scenarios? And what happened in the process, has to do a lot more than this IOL lenses. I'll briefly mention what happened there. Okay. What are the other costs involved in this? Okay. So, and you could also see the transformation in numbers very well. So this is by Aravind Eye hospitals. The cataract surgery is done, percentage cataract surgeries in the y-axis. This is years. Notice the 1992, about 65% of the surgeries, cataract surgeries, were done without IOLs, right? Only like 35% had it. So the work started kind of well before that. This Aravind Eye Care hospital was founded by Govinda Swami. And starting from like 35%, more and more IOLs in a span of about 10 years, 90% of the surgery, 95% of the surgery, mostly all of them use IOLs. And by the time, this report was written, almost all surgeries, if there is most of them, right now, a small percent doesn't use IOLs because experience tells that those patients doesn't need an IOL. Only those patients not put. Almost every other surgery it is put. Okay. It was an impossibility here. 1980s, 1970s, it was a standard in Western world. It was an impossibility in India, a developing country. over a course of 20-30 years, it became a reality. Okay, and that part of that, actually, the almost everyone who works in that gives credit to the vision of Dr. Govinda Venkateswamy. He thought such a thing was possible. He imagined such a reality, not how it will happen and all that. What if such a reality happens? He foresaw that, and that reality eventually took real shape. Okay, so this transformation happened, and in the course, you might have heard of this, right? The chain is as strong as the weakest link, right? But there is also a corollary. So first of all, you don't form a chain if there is any gap in it. From a technology solution point of view, biomedical solution point of view, you improve one aspect of 10 other things 100%. In fact, you are doing one aspect better than everyone in the world. Doesn't mean that will work in a realistic setting. For that to work in a realistic setting, you have to get all the 10 aspects, or if there are 10 aspects, you have to get all of them working in an affordable, accessible way. So intraocular lens was just one aspect. If we just brought down the cost of intraocular lenses, it wouldn't have become a reality. Again, bring down the cost of intraocular lenses is not a reality without making improvements in other parts. Okay, so they go hand in hand. Improvements happen in all frontiers, not just from a technological point of view, but from an economic point of view, from management or management organizational point of view, from every point of view. Okay, and again, the reason to have this is often we as engineers, we focus on technology, but technology alone takes long time to become a reality. Technology along with refinements, sophistications, appropriate adaptations in every other involving front is only make it a reality. Okay, so here is a proper cost comparison. Okay, what other cost is involved? This thing cost at 4,000 rupees. A farmer, a daily wage worker cannot 4,000 rupees back then was actually a lot of money. Okay, people used to earn like monthly salary used to be 300 rupees and all that. So 4,000 was a big chunk. Even 800 was wasn't affordable back then, 20 years, 30 years back. So, okay, the IOL cost came down. What other costs were there? So you need an operating room, right? Let's look at the cataract surgery cost in India. You need an operating room. We have a setting, okay, where things are kept sterile. Our volumes, number of operations we perform is very, very high. The costs are like roughly $3.2. Let's have in dollars so that we can make the comparison. Operating room cost in USA during the same time is like $760, right? Okay, then we have like supplies. One of the supplies, notice this $200 roughly is like IOL, right? And then you need a couple of other supplies. You need a bandage, you need a you need a suture to close it down, you need a scissors. So there are some supplies needed. Cost of that is $300. This IOL makes a majority of that. Here supplies $7. The IOL cost is $4. And then pharmacology, you also need drugs. You don't want infections, you want it to heal and all that. Drugs is $249. And with complications, fungal complications, so many other complications here, drug cost is $1.72. And then of course you have to pay the nurse, you have to pay the person who is diagnosing, who is driving the van. There are many other notice. It doesn't suffice if something becomes affordable. Okay, again, to give a very specific instance illustration, Aravind Eye Care hospital made this affordable, but people, farmers In order for them to make that surgery, they have to take a day or two off, get to the place where the surgery is being done. They couldn't afford the travel cost. They couldn't afford that loss of pay for a day or two. So they thought, okay, why don't we also put that account for that cost, pay them to travel or arrange them travel, at least feed them for the days when they are there, and they worked on that front and made it more accessible. If they didn't do it, it was affordable but not accessible, right? Arranging a simple van to pick up someone from a rural area to a actual operating room, right? That cost, that also should be addressed. Partly the other cost, there are hidden costs like that, right? And of course, from a business perspective, one has to properly account for it. Notice other cost, we have to do the same thing. It's $400 pretty much in every other font. Okay, labor, everything. Labor, it's not simple labor. These are doctors, trained ophthalmologists, and not all ophthalmologists know to do surgeries. They can tell you have a problem with the eye. To correct the problem, you need another level of expertise, right? Their labor is very different, and they also need the training to actually get to that state. So there is, and that is a direct labor cost. There are also indirect labor costs. So we are doing better in almost every front, specifically Aravind Eye Care hospitals. Okay, and at this point, everyone might think, okay, we compromised on quality, right? Interestingly, no. To give a very specific instance, the IOL cost became 100 to 4. The same equipment and manufacturing process that were used to make this $100 lens was used. Okay, regulatory requirements, CE standards, ISO standards, right? Were they skipped? No. Eventually, they fulfilled all the same regulatory requirements done by this, $100 companies. And in fact, only when they could do it, they could also start selling it to, exporting that IOL to other countries. Without the regulatory requirements, you cannot start exporting and competing with these things, right? They didn't compromise in quality, same equipment process, same regulatory requirements, okay, same quality used in, America, Europe, or elsewhere. And so where is the difference? Difference is actually, it's not low quality. Difference is actually much higher quality. The goal of the company which is making this $100 is profit. The goal of this, in this case, the Aravind Eye Care hospitals and the Oro Labs that manufactures this lens and many other accompanying things, their goal is maximizing service. This actually higher quality, incomparable quality, to maximizing profit. So, in simple terms, we have world has resources for everyone's need, but not for everyone's greed, right? At some point, the profit kind of gets morphs into greed, right? So that is the difference actually we are looking at it. They did not compromise on quality, okay? And it boils down to this thing. People are blind. We know it's, we are all compassionate. We can see the effect that it has on their lives. And the moment they get back their sight, we know the effect. So can we make it a reality, right? That mindset is what made this possible. That also you all should know, okay? So to list down actually the list of things that, primary things I did. First thing is lens manufacturing. Why import lenses? Why not manufacture it here? That wasn't simple, okay? Notice lens is just one part, right? It's a plastic that is like kind of polished to a specific dimension and all that. Not like electronics, not like multiple parts, so and so from issues. But still at that time, manufacturing in India was a big issue. But somehow the technology transfer happened. Oro Labs is this manufacturing wing of Aravind Eye Hospitals, again started by Dr. V. Okay, so the technology transfer happened from lens side. Okay, we brought down the cost of the lenses. Is that fine? No. The doctors who are here should be trained to actually perform that experiment. Just because we got some technology doesn't mean that it will be used, right? Doctors should know how to use it, right? The training is often costly. Okay, even that clinical training was happened. And many a times starting this is extremely difficult. The moment you have some critical mass of clinicians who are very good, training further clinicians is very easy, but to start it, okay, extremely difficult. Again, that happened. Then this missing gap in the chain, not just the IOL, we also need many other things. We also need sutures at a very affordable cost. Then sometimes they need to inject viscoelastic material into the eye to keep its shape and all that. That is called viscoelastic or ophthalmal. This is OVDs. Okay, and those viscoelastic material gels that are being injected into the eyes to retain its shape, that also had to be manufactured. Okay, does manufacturing suffice? Not really. Okay, so all this points to a ecosystem of eye surgery, right? One needs an ecosystem, not just a part of it. One animal will not make a wildlife. In order for a jungle to be alive, there is an ecosystem. There are trees, then there are carnivorous animals, then there are omnivorous animals, herbivorous animals, right? And we need water. So many, that ecosystem needs to be there. That was put into place. Okay, in technical terms, we call it a supply chain. The supply chain and the delivery system was established. As I said, okay, we have the supply chain, we can make things, we can also get it to the door. But can also that be delivered? Yeah, there is a person to deliver it, but the person to whom it's being delivered, will that person come there? The delivery was also addressed. Part of that goes into optimization of protocols. Okay, the number of surgeries that were done by this Aravind Eye hospitals, no other hospital in the world could match it in terms of speed, in terms of quality. So post-surgery complications were minimal here, where they were doing more number of surgeries per minute. Okay, so optimization of protocols. You have to go wait in the waiting room, then the doctor will have tea, then have some chat, get back to the patient. 6 o'clock meeting will show up at 6:05 and all that. That's highly inefficient, unoptimized. You do a surgery here in the left hand side. By the time you're doing it here, your assistant nurse gets the next person ready. Another table here, second table here ready. So that as soon as you finish, the doctor who could actually do the experiment could turn and start doing the surgery here. Okay. And while he's doing the surgery, that bed will be cleaned up, vacated, next person will be made ready. So he finishes this, he gets back to this. And then, so that in fact, such kind of optimization of protocols did happen. And the thing is, not just this, doctors are actually a critical bottleneck. Ophthalmologists who could perform the surgery were very critical. So can we do screening, diagnosis by someone who doesn't know not by doctors, but someone who is trained and qualified by support staff, nurses and all that. That will take the load off the doctors. That will give doctors more time to do the critical job. That was also addressed, right? So optimization of protocols. And then economies of scale. See, developing country resource constraint thing, one way to look at it is, we are short of everything. Another way to look at it is, we are actually abundant in terms of numbers. It's not 1,000 people who are blind. It's 1 million people who are blind in this market. Okay. So interestingly, there is this concept in economy called economies of scale. Again, not a big deal, right? You go buy bananas, 1 banana you will pay 5 rupees, right? 50 bananas, you won't pay 5 times 50, 250 rupees. No one pays 250 rupees. 50 bananas get a concession, 200 rupees, something like that. 500 bananas, again, won't be 500 times 50. There will be more concession, right? How about 5,000 bananas? How about 50,000 bananas? How about 5 million bananas, right? Interestingly, what it is uh, when you're dealing with more and more numbers, more and more volumes, by making a very small profit, but the number of such profits is so high in the level of millions, you can make more money than, who is working with, 1,000 bananas or something like that. In this case, 1,000 surgeries or something like that in a developing world. So there is this thing called economies of scale. Again, that was exploited. Improvement of access, I again mentioned. Someone couldn't actually get to the operating room, that was worked on. And then they needed some pharmaceuticals and supplies. And something like antifungals were very, very specific to an Indian issue. Not necessarily related to cataract surgery, but there were some fungal infection related, blindness. To cure that, they had to manufacture antifungals. So they pretty much worked on creating an ecosystem that was appropriate for a resource constrained setting with millions of people, millions of patients. Okay. And many times they had to, this is not compromise on technology or quality. These are innovations in technology, and these are actually better outlooks, perspectives on quality, better manifestations of quality. So catching up, okay, I think the 723, you heard the story, how the transformation happened, and where are things right now, so starting with, remember, primitive VCC, Sushruta, then most of the world was doing coaching. Then 1750s, someone realized, okay, you could do ICCE, remove that lens. Then, okay, removing the lens, essentially the person is blind. Now he doesn't have a lens to focus. So, okay, put a glass. Then someone realized you can put an IOL, 1950s. Then ICCE has lots of complications. You could do ECCE. That happened in the developing world. I mean, developed world. In the developing world, ICCE with FAC glasses was still the norm, but somehow some very compassionate humans, they changed that scenario. Now our standards are here. This happened in 2000s. Right now, what they did is, okay, why put a IOL that is like, rigid, almost rigid? Why don't you, fold it, put it through a small incision and then unfold it? So there came this foldable IOL. And also notice, removing that big chunk out of the eye needs a very big cut. But if you kind of liquefy it and suck it out, you just need a syringe or a tube, right? So phacoemulsification kind of made a big difference. Now this is also being practiced, okay? And then MISIX, this manual small incision cataract surgery. Even phacoemulsification, this is called phaco. This needs some equipment, this ultrasound to actually liquefy the thing. That's, why that equipment? So someone thought you could actually do the surgery very, very cleverly in a specific way. Okay, keeping the eyeball watertight and get the lens out of the eye through a small surgery, watertight surgery. I mean, watertight as in this, this lots of water in the eye to the two chambers we looked at it, that will still remain intact. That won't be touched. They will access just the lens part through an incision, remove it. And that's also a small incision. They figured out how to do it. And this, I think this was discovered in Nepal in 2010s or something like that. Okay. Again, Nepal is a developing country, a resource constraint setting. You come up with innovations, all your creativity, all that shows up. So now pretty much these three are the standards. Okay. That's a very, very nice story. That means millions of more people have vision, have sight. Sight is affordable, it's accessible, and it has transform the lives of millions. Okay, so that happens because of revolutions in all fronts: engineering, technology, supply chain management, or basic psychology, whatever it is, right? It happened in all fronts. Then where this is headed up is better biomaterial lenses. Okay, PMMA, how long should we stick to PMMA? Can we make it, some other material? Can we make it hydrophobic so that, say, things, infections and all that, infection rates drop? Or, better example would be precision IOL. Can we actually control the lens through electromechanical means, right? At the end of the day, it's some, if somehow the lens reacts to external field or a magnetic field, you'll be able to change focus, right? But this doesn't apply in an Indian setting, right? At least in a developing world setting. But these are questions that are being currently asked. Okay. And yeah, right now, so notice many times you'll have to leave the ladder that you used to climb. When you are doing ECCE with IOL, coming manufacturing sutures was such a big deal. Getting a manufacturing plant started in India, manufacturing it sufficient enough to address local demand, then sufficiently to address global demand. Somehow you got to that stage and then realized actually you could do sutureless surgeries that are actually, clinically showing up to be better. You already put lots of money into that manufacturing plant. Sometimes you have to either, change it to some other thing. You have to let go of that. You have to leave that ladder. And of course, these pioneers are somewhat in that kind of dilemma. Many of the technologies they toiled, day and night to technology and processes, toil day and night to make a reality. Now already many of them became obsolete. Examples are sutures, right? Now how do they run a business out of it, right? Those questions are being addressed. And outside, developing countries, of course there are questions. Can we make it, okay, there is a lens, but the refractive properties of a lens doesn't match. It's not patient specific. There are lots of issues with that. Can you be corrected after surgery? Can you make it active and all that? Precision IOL or questions, big questions still out there. And yeah, this is a story with cataract eye surgery. I just said the point of this discussion is not to stop at this story. Okay. The idea is, okay, such a beautiful thing happened with cataract eye surgery. Where can we venture out? Can such a beautiful picture reality show up in other aspects of healthcare? Okay. That is, in fact, the reason to have this conversation with biomedical engineers. Closest to cataract eye surgery, diabetic retinopathy, right? So with diabetes, there is loss of vision over time. And right now there is technology to actually correct it, stop loss of vision through some, again use laser, but for photocoagulation. But interestingly, this laser is very costly. Can we bring down the cost of that laser? Notice, although, I said the flax is not, flax is not, not appropriate for an Indian setting. LASIK is very, very appropriate. And in order to do that LASIK, they had to actually do major innovations in laser and accompanying technology. They had to bring down the cost of that laser. This is, I think, yttrium aluminum gallium laser or something, YAG laser. They had to bring down the cost of that laser. They certainly needed engineers to do that. There is an operating microscope. It's a very precision surgery. You need a microscope to do the operation. They brought down the cost of that operating microscope. Of course, they also brought down the cost of that IOL, intraocular lens. So all these three things happen. Almost a similar thing scenario here with lasers. That is diabetic retinopathy. Okay, diabetic retinopathy, we have the technology to stop that loss of vision, but it's again very costly. Can we bring it down? But the question is, you can't just work on one aspect of the technology. You have to work on changing the ecosystem of the technology. Okay, that is the teleophthalmology. Can we make this more, diagnosis much more effective, efficient by making things remote telemedicine possible? Is a big question. Okay, so the person cannot take a day off, daily wage worker. It's big money for him. Can you make it? Again, for some reason the expert, one ophthalmologist available for 10,000 patients is not able to travel to all the 10,000 patients. Traveling time is lost. Can the traveling time be saved using telemedicine? That's a big question. Again, slightly venturing out of eye surgery, what is preventable blindness? Is cataract only preventable, or there are other forms of blindness that are preventable? This is very, very important. Okay, when you are solving a problem, take a get question. That question better have an answer. If an answer doesn't exist, how much ever time you spend, you're not going to find it. You're just going to end up spending more and more time on it, right? So that word preventable is extremely important. Okay, there is blindness. Just remove that cataract and make up for that removal. That blindness is preventable. So recently, the question is, many blindnesses we thought were permanent or becoming preventable. Of course, advanced therapies based on stem cell and all that. Okay, this is happening. Again, there are problems with infection. You take a stem cell sample, try to culture it. Next day you see it's full of fungus and bacteria, right? How do you do that in a remote setting? Again, there are so many questions open out there. Again, as engineers, focus on one technology, one aspect of the problem, but as a community, we have to address the ecosystem for it to become a reality. Okay, primary healthcare centers. So most people don't have, cities. We have all this. Every street there is a clinic, right? And remote areas, rural areas, the clinic is not there. There is a primary healthcare center. What they can do in the primary healthcare center is very, very limited. Many of you will have first-hand experience, right? Or from villages. So what technological innovations, modifications need to happen? What process modifications need to happen? Okay, what device need to be there in the PHC so that more diagnosis, screening can be done, or more treatment can be done, right? Questions like, again, telemedicine is a very, very big thing. It's not a reality yet, but the telemedicine can change things, can have a drastic impact on medicine. Again, solar energy is extremely important. Okay, rural areas, even rural city areas, there is a power cut for every day there is a 2-3 hours power cut. I have a refrigerator where I have to keep the vaccine. There is a power cut, that's it. The vaccine, all of the vaccine, or they can't be used anymore. I need sustained temperature control for that, to preserve that vaccine, right? Getting power to remote areas is hard. Fortunately, we have this boon of solar energy. Generate energy where you need it, right? Again, there is a revolution going on in there. As biomedical engineers, we don't have to get expert at solar energy, but we need to work with engineers, who are experts at solar energy. We need to collaborate with them. Again, as a community, we have to address the ecosystem. Solar energy is a big part of the solution in that ecosystem. Emergency care. Someone has a heart attack in a remote village. I visited Chidambaram 2 weeks back. I said I was traveling, right? They said someone has a heart attack. They can get a first aid in the hospitals, big hospitals out there in the city. That is, there is a remote village, there is a city nearby spokes. Someone has a heart attack in a nearby spoke, they'll be taken to the town Chidambaram, where there is a big hospital. There they can only do first aid. In order to get first aid, or like perhaps they can give drugs. In order for that to be treated, they have to go to a nearby city or a urban location, which are like 3-4 hours away, right? So what emergency care devices, things, what are the devices we are currently using that we borrowed from the Western world, but what modifications need to happen in emergency care? That needs to, that question needs to be addressed. And again, a part of that is drone technologies changing things. If you are not pilots, we don't get pilot drone license. That is fine. We are not technology experts at computer vision, all of that, drone, flight control and all that. That is fine. We need to collaborate with people who know that to make it a reality. Same applies with any other disease: heart disorder, stroke, obesity, tuberculosis, cancer. Okay. If we have time and interest, idea is today we started with cataract eye surgery. We want to develop depth and breadth. Idea is to venture into as many. There are success stories elsewhere too. Every other place there are success stories. Heart disorders, there are, we started manufacturing stents. There is a story behind that. Then tuberculosis, lung cancer, there is a story behind, we are not silent, or we are not inactive about this disease. Our doctors, our biomedical engineers, our citizens have been doing something about it. There is a nice story about every other thing listed here. So given time, of course, we want to eventually address, discuss all this. Okay, today we did cataract eye surgery. If we find time, if you all find time, if you all know there is interest, we want to do this. Okay, and of course there are so many other disorders not mentioned here. I just mentioned some cutting edge, very, very active regions, and very impactful disorders. Just like cataract eye surgery makes a major chunk of blindness, heart disorders, cancer and all that make a major chunk of diseases in the developing world. So time for disclaimers. I talk about a lot of surgical procedures and all that. I am a doctor. I am an engineering doctor. I have a PhD, right? So idea is to have a conversation, discussion among biomedical engineers, and also among healthcare community professionals, and also even the masses population should be aware of all this. That is the reason to have this conversation, primarily for educational and research purposes. Okay, so many of my references, many of the images I used, text I used, I think I have put up references then and there. If not, this should be available on request. And just in case this video goes outside, of course, whatever I said is not medical advice. This is just discussion for these purposes: criticism, common news reporting, teaching, scholarship, education, and research purposes. Okay. So, okay, with that minor disclaimer, let's end with a very, very positive note. What is our greatest strength according to Dr. APJ Abdul Kalam? Someone without Googling.
Always we need to have a goal, or we need to have a vision. So
Always you need to have a vision. So interestingly, yeah, that is correct. But what Dr. Kalam said is, any other guesses?
if there is any failure, or if there is any something which is stopping from that goal, we need to give up. We should never give up from that particular goal.
Yeah, amazing. See, in fact, what you mentioned, he has mentioned many of these things at different places. Vision, focused vision. Okay, so as a teacher, I am trying to look at all these diseases. But at your stage, focus on one. Okay, vision needs to be focused. Have a very clear vision. So, and if it's quantifiable, that is better. That's why I showed the numbers earlier. There are like roughly 1.6 to 1.9 million operations being done. Can we make it 5-6 million every year so that we can actually match the demand? Right? That's a very quantifiable vision. Yeah, that one focused vision, Dr. Govindappa, and that focused vision, there was actions, right? Not just dreams. The dreams turned into actions. Lot of knowledge, effort, sweat, all of that went into that. Things are hard work. Okay. Any good thing, it's hard work. But what makes things, again, I'll my words are not that impactful, so I have better words for this. But just because something is hard doesn't mean it is not enjoyable. It is going to be, just because something is strenuous doesn't mean you won't like it. Many great people do very strenuous things. Difference is they like it actually, that strenuous process. Simple example is Arnold Schwarzenegger was building muscles. If we do go to gym, lift couple of weights, we'll feel the pain, right? When Arnold Schwarzenegger went to gym, he did the exercise, he felt pleasure. He had the pain, but he didn't see the pain. He saw what was following that pleasure. He had the vision, that pleasureful vision that followed his pain. That is important. Okay, so vision, focused vision, extremely important. The more precise you are, the easier for the vision to manifest. Don't worry about how hard, how impossible the vision is. Have a very precise, focused vision. Easier it is to manifest. Okay, nature has this amazing habit of doing that. I told you our sight has a very, very restricted spectrum of vision, right? Somehow, but we wanted to see things so we can see the entire universe, right? And this is again quoted by Dr. Kalam. In Tamil, this goes by வெள்ளத்தனைய மலர் நீட்டம் மாந்தர்த்தம். What is it? Can someone complete the quote? உள்ளத்தனையது உயர்வு, right? Idea is, whatever is the depth of the ocean, the lily flower will come to the surface. It won't be worrying, okay, it is 2 meters deep, it is 10 meters deep and all that. It wants to come to the surface to see the sun. It does come. That's it. So that vision, focused vision, is extremely important. Notice sunflower's vision is very focused. It's directed towards the sun. So does most plants' vision. They are all directed towards the sun, right? Your vision needs to be very focused. Then it is focused. There are efforts to back it up. Then you keep on acquiring knowledge and then convert that knowledge into actions. Magically, the vision becomes a reality. In fact, today we saw one such story. And to answer to this question, what is our greatest strength according to Dr. APJ Abdul Kalam? Again, we have that in the chat. It is the ignited minds of our youth. I don't know if I am counted as youth. Okay, by most standards, I'm still young. Okay, I'm also like to belong to your category. But when you're young, your possibilities are tremendous. Acknowledge that. Okay, nothing like excited mind of a young person. Okay, again, so to change the world, what do you need? One of our leaders, national leaders, very knowledgeable person, said, I just need 10 motivated youth. Remember that? Who said that? I just need 10 motivated youth to change the world. Okay, this was said by Swami Vivekananda. Okay, again, so there is nothing more powerful than youth. And there is nothing more, in fact, powerful than your ignited, excited minds. Okay. So that also is what Dr. Abdul Kalam also pointed towards. Our greatest strength is our youth. And the point of this conversation is of course to ignite that youth. Okay. So there are some very, very specific takeaways. Yeah, we noticed so many things, but let me also clearly point them so that we had some very clear takeaways from this. We noticed some amazing evolution of technology and roles that BM engineers and scientists play. PMMA, laser, and 2 examples. And then most important thing in healthcare is context. Where is it being done? Whom it is being done? Right? That context is extremely important. Something works in developed world doesn't mean it will work in a developing world. Okay, there is an MRI machine to do some sophisticated diagnosis. That MRI machine fixed to a room, it's not going to be useful for most people, not a remote region. Maybe you need that MRI machine in a vehicle, something like that. So the context is extremely important. Then affordability of, you have to make the technology affordable. Technology alone doesn't suffice. It has to be affordable. And affordable technology alone won't become a reality. There needs to be sufficient supply chain and delivery. There are, things are interconnected. Realities are itself, they have a life of their own. Just like different parts are working together in a human body harmoniously, reality is like that. You need multiple so-called parts working together as a whole. Affordable technology, you need supply chain, whatever you need, not just the lens. You need a suture, you need that. You need that medicine, you need that. You need doctors, you need that. You need the drivers, you need drivers to that remote area van, you need that. You need drones, you need that, right? And the more self-sustainable you make it, fine. Surveys, at the end of the day, you have to make things affordable, but not free. Money is, I don't give importance to money. Okay. Better quote is, we don't do things to earn money. We earn money to do things we want, right? So money does have a role to play, but that shouldn't be the primary motive or role. Okay. And free things, not that self-sustainable. Okay, humanitarian efforts, all that are great. If you somehow make it self-sustainable and at a scale by giving something life, nothing more beautiful than that. Okay, so we saw an example for that. So we saw a model for this. So picture of indigenous development of medical technologies in developing countries. So the idea is this, to give you a picture that has worked, one of the best pictures, to show you that picture, so that when you are imagining about your future, about the country's future, there are some seeds of that picture and that vision. Okay, to show you some pointers, to sow some seeds in your vision. Okay, so that was the objective of this this discussion. And we'll hear whether how many of these takeaways were met, how it was met. That the actual answer to that we'll only know 10 years down the line, 20 years down the line. So having 1 or 2 comments, not all that. It will make us feel good for some time, physically make me feel good for some time, but let's see what happens 10 years, 20 years down the line. Okay, so let me also finish. Okay, there is at least I'm certainly older than you. Okay, I might be a youth, young and all that, but you are all younger to me. There is one thing that I have learned from my life. Okay, focus, vision, effort, action, little bit of money, self-sustainability, community, collaboration, all that is fine. But you need one more thing. So what do you think made Dr. V do all this? if we were to pinpoint, okay, we never spoke about him or like any of that. I mean, his attributes, or only we spoke about his work. But there was one aspect of Dr. V that was key, that was foundational, that was fundamental to this beautiful, eye surgery reality. What do you think it is? And I also given a
Sir, maybe he have experienced such a situation in his family or in his environment. Sir.
yeah, we get motivated by that. Yeah, that's partly that. His story. He was a doctor. He was an obstetrician. By 30 years, he got rheumatoid arthritis, so he couldn't perform that deliver babies and all that anymore. Obstetrician, right? He lost his this controls, and rheumatoid arthritis, right? So after 30, he learned ophthalmology. He worked in a government hospital, I suppose, and he was holding the record for maximum number of surgeries made per day, about 100 surgeries per day. And then once he retired, he started Aravind Eye Care hospitals. Okay. And all of that, I believe, in fact, he has also said this due to one specific aspect. Partly what you said, almost there.
Self-love and self-love, sir. Maybe self-love and love for people. So we want to serve people, sir.
Okay, that is so self-love. Who is a self here? Dr. V the self?
No, sir. I mean the people around him, sir.
Yeah, that was the thing. See, in fact, that's why you have this quote. It is ourself we are helping. No, it's not someone else you are helping. It is ourself. The self is over here. Recognize that, and it's ourselves we are healing. Okay, this is one of his quotes. My favorite quotes, and it boils down to self-love. Self-love as in not like liking, myself or yourself, right? Seeing yourself in others. In one word we use for that in English is compassion. Again, you face a problem. What if that person faces, there are millions other people in the world facing the similar problem. Okay, I want to correct my problem. What if I correct problem of million other people? Okay, I don't have that problem, but million other people are having that problem. Can we relate to that? Can we, can we relate to that and respond to that? So loving oneself is actually correct, but be very careful on what that self, how you interpret that self. Okay. So, and it's best stated here, it's ourselves we are helping, ourselves we are healing, and of course intelligence and capability are not enough. Just because someone intelligent, just because someone has money, someone is capable, someone is trained, someone has a degree, all that doesn't matter. Okay, at the scale of things we are talking about, healthcare transformations, these are societal transformations. Okay, we need first of all that compassion, and you should have that joy. So even if one student shows up for the class, you should feel like taking that lecture, right? That joy of doing something beautiful. When you do something beautiful, that you feel it. Oh, this is good. Oh, this is something right. Yeah, I'm feeling better, right? When you do something bad, that something bad or something not beautiful, you yourself know that's not all that good. Somehow I don't know why I did that. I don't want to do it and all that, right? So the work that you do, that focused action, you should have this joy of, you should see that beautiful vision, that beautiful picture. You should be like, you should have it in front of you, and there should be that, joy of just doing whatever you're doing. It's not about, getting that gate exam, preparing for gate. Preparing for gate never becomes, unless there are ways to do it, it doesn't become like playful or like enjoyable. but there are means to make it enjoyable. How you look at your gate preparation, So you all joined here because of gate exam, but we are learning biomedical engineering, right? There is something nice about doing this, right? So always try to find something that the joy of doing something beautiful. Okay, the this is the moment you find it. You find it once. You'll keep on finding more. Initially finding it is very hard. The moment you find it, more and more will find you. Okay. So anyways, so I think it's also about time, 8 p.m. Let me stop here. So be compassionate, and yeah, I wish you all good luck. Happy Diwali. So we had this festival of lights. Now I think I have time to have a festival of vision, right? There is also like World Vision Day and all that. So yeah, have a wonderful vision. Work towards that, and let's see what happens 20 years down the line, 10-20 years down the line. Okay, so until then, any questions, comments, we'll wind up at 8. Okay, let's give respect to time once. 3 more minutes, some brief conversation will wind up, else yes. Any questions, sir? That slide, that picture, what does it mean that there was spelling mistake? Anything?
Sir,
Mhm.
you mentioned that antifungals,
Mhm.
that infection, when it may occur, or during which situation that occurs, sir?
Oh, this is corneal fungal infection. Just Google for it, right? It doesn't necessarily have to do with cataract surgery. After you do the surgery, that fungal infection, no, not like that. Just that it's more prevalent in India. And in fact, now that you raised it, let me also answer that. So who am I to talking about all these things? So I'm just someone who finds joy in doing this. Okay, joy of doing something beautiful like this. I had like a somewhat of a disclaimer earlier, but I just like doing this. That's why I do it. So all this information, I just I was curious, I was interested. So I learned about it. Okay, so best answer for you: fungal infection. What are the conditions? When does it occur? Go Google it, learn about it. Okay, once you learn sufficiently about it to have a discussion with us, even a 5-minute discussion, tell us. You could come tell us what you learned. Okay. Rajeshwari.
Yes, sir. Okay, sir.
Yeah, you always ask, okay, multisim, why you multisim? What was that other thing you used? Yeah, antifungals when it is happening. Yeah, that's a nice question. Yeah, we have at least knowledge is accessible, right? Go explore. I'm also like I don't know everything, right? Even eye cataract surgery is just like things that I learned out of interest. So okay, others. But always, look for things that this is not available in a single research paper. It's not available in Google. Yeah, Google, you read, you spend 1 year, you can learn whatever you learned in this one meeting, right? In 2 hours, you kind of learn so many things that you couldn't have just learned by Googling. So even if that information is available, giving it a structure, giving it some direction, organization, it's very helpful. So do that. And in fact, if you get back to me that, okay, I learned about fungal infection, 2 minutes, I want to talk to class about it, I'll be very, very happy. In fact, any of you do that, I'll be extremely happy. Okay, not just about fungal infection, something else. LASIK, what is LASIK? What happened, right? Phacoemulsification, what is that? Any of that, stem cell therapy with, parental blindness, where are we? Any of that, if you do that, we'll be happy. It's okay to make mistakes as far as we know, we identify it and we correct it, and we have sufficient sufficient intelligence to do self-correction. So don't be afraid of failures, don't be afraid of mistakes. Go explore, learn something, let us know, so that we'll learn that in 5 minutes, 1 hour, whatever it is. Okay, it is time 8:01. Anyone else? Urvi? So Urvi has written many research articles, published research review articles and all. How did you find this, Urvi? Can you make this review article?
So yes, sir. I couldn't hear you. Can you repeat the question?
No. What did you think? I was just joking. Simple thing. So what did you think? How was this? Was it like?
So it was very informative.
Informative. Okay.
And yeah, and definitely, sir, I think a lot of research can be done on this.
Okay, excellent. Okay, so that is good. Research, and eventually that research. Let's make it translational, realistic research. Realistic research, that is something that becomes a reality. So wish you all good luck. Wish you all happy Diwali again. Okay, so many of you, I'll see you in tomorrow's class. So we'll start again. Okay, so have a good one. Bye everyone. So bye.
Thank you, sir. Thank you so much.
Happy Diwali, sir. Thank you.
Thank you, sir.
Thank you, sir.
Welcome everyone.
Thank you, sir.
Yes, have a good one. Bye.